my conflicts of interest. None of them is directly related with the content of the presentation. So the first question is, what do we want to achieve when we grant some form of respiratory support to a patient with acute respiratory failure? Well, there are three objectives of non-invasive support. The first one is to prevent endotracheal intubation whenever possible and the associated complications with intubation. The second, obvious, is to improve gas exchange. And the third one, as we've heard from Leo, is to avoid self-inflicted lung injury, so to avoid that excessive drive and effort may worsen and maintain the lung injury. So these are the three main goals of non-invasive respiratory support. And so when we start any form of support for a patient with respiratory failure, we want to achieve a couple of objectives. The first one is to avoid alveolar collapse, and the second one is to support the failing respiratory muscles. So when we go to non-invasive support, we have basically, I would say, two main scenarios. The first one is the purely hypoxemic patient. And in this patient, at least in the initial phase, the goal is mostly to increase mean airway pressure, so to counteract the tendency to alveolar collapse. So what we do is, again, increasing mean alveolar pressure and increase FiO2, obviously. So at least in the initial phases, my personal choice would be to use CPAP. And for CPAP, you know, I am Italian, so it's almost, this is probably a disclosure of interest. For CPAP, my preferred interface is the helmet. The second scenario is a patient that has hypercapnia and or is developing fatigue. So in this case, what you want is to reduce the work of breathing. You want to unload the respiratory muscles, and for this, you need some form of positive pressure ventilation so that the patient and the ventilator share the work of breathing. And so in this case, you need non-invasive positive pressure ventilation. And for this, you can use both mask or, again, the helmet. As you know, there are many interfaces that can be used to apply non-invasive ventilation with a ventilator, for example. And since in patients with acute hypoxemic respiratory failure have prevalently mouth breathing, the most commonly used interfaces are face mask, total face mask, or the helmet. This is a very nice, I would say, very nice review by Domenico Greco published in Intensive Care Medicine that compares advantages and pitfalls of high flow face mask and CPAP. So let's forget for a while nasal high flow, and let's concentrate on face mask and CPAP. You can see that there are different settings. With face mask, you need to apply some sort of, let's say, pressure support with a ventilator, or at least a bi-level ventilation. You can use also face mask for the CPAP, but as I told you already, I think that for CPAP, the helmet is a much better interface. The helmet has different settings, as we will see later, whether you want to use it for CPAP or for pressure support. If you use for CPAP, it's better to use it with free flow system rather than with the ventilator to grant enough bias flow to avoid CO2 rebreathing. Both interfaces have benefits, and you can see them here. Both deliver a preset and granted level of FiO2. They both grant relatively high levels of PEEP, especially the helmet. They can both provide pressure support. And if you look at on the right-hand side at the bottom, there is one sentence, and I will discuss it later, that surprised me a bit, because When you think of non-invasive ventilation, you think that the most important issue is patient-ventilator interaction and in some way also the synchrony between the patient and the ventilator. But if you look there, in the benefits of the helmet, they say asynchronous pressure support may prevent positive transpulmonary pressure swings. And in the pitfalls of non-invasive ventilation with the face mask, the third point is full inspirator synchronization may increase transpulmonary pressure swings. So this is an interesting concept that I will review briefly later. So in the second part of my presentation, I will focus mostly on the helmet. So the first question is the helmet actually better tolerated than the face mask? There are several studies. These are two old studies from two Italian groups. And as you can see, there are apparently low numbers, observational studies, but apparently it seems that the helmet has a better tolerability both in patients with acute hypoxemic respiratory failure and in patients with COPD exacerbation. If you look at the Antonaglia study, you can see that the cause of intubation in COPD patients randomized to mask non-invasive ventilation or helmet was intolerance more frequently for the face mask rather than with the helmet. So, which are the pros and cons of the helmet? The advantages are listed here. So, low gas leaks, lower risk, I would say, not no, but lower risk of skin lesions. Of course, in pandemic situation, like lower risk of environmental contamination. The helmet grants stable and probably higher PIP values. Of course, you can deliver a non-stable FiO2, and it's the better tolerability grants a more prolonged period of treatment, and we all know that improved patient comfort means probably more time with the device, so more time with positive pressure applied at the airways. Disadvantages are, of course, the dead space of the device, so the risk of CO2 rebreathing, then, which means that you need a certain bias flow to wash out the CO2. Again, the risk of asynchrony, I put it here, but as we will see, this may be seen as an advantage or a disadvantage. Of course, claustrophobic patients may not tolerate the helmet. There is a problem with the noise, and very important, you have no clues on tidal volume. At least there are now studies showing that you can try to measure tidal volume. There are also non-invasive methods of measuring tidal volume. And as we have seen from Leo's presentation, tidal volume during non-invasive ventilation, non-invasive support, is a determinant of lung injury, or at least is a proxy of the risk of the failure of non-invasive support. If there are two different settings, if you want to apply the helmet for CPAP or for NIV, helmets modified for NIV have basically a lower, are smaller in order to reduce the dead space. And these are the main problems with the helmet. So the first one, again, is CO2 rebreathing. So if you want to apply CPAP with the helmet, you need at least to apply 30, but I would say higher, ideally 50 to 60 liters per minute of fresh gas flow to remove the CO2. And if you use it for NIV, again, you have to take care of the problem of the risk of CO2 rebreathing. The noise, the problem of noise can be solved with the use of air filters or earplugs. There is an issue with humidification. It is possible to humidify the helmet, but it's a bit complicated, and it's an issue because otherwise the internal surface of the helmet becomes all wet and it's like fogging. And then, as I told you before, there is the issue of patient ventilator synchronization. So why is this? Because as we know, the helmet has a large surface and it's a compliant device. It's compliant interface. So the ventilator takes time to inflate the helmet. And for this reason, there is always a huge delay between the moment when the patient starts breathing, and you can see on the right-hand side from the esophageal pressure tracing, and the moment when the ventilator delivers the assist, and then there is the time which is needed to pressurize the interface. The compliance, the volume of the helmet, and eventual air leakage in some way make difficult to obtain a good patient ventilator synchronization, at least in terms of timing. And for this reason, when you use the helmet for non-invasive ventilation, you need to apply special modified setups. In particular, you should apply higher PEEP levels to make the interface more rigid, and you have to try to apply very short inspiratory ramp to grant the highest possible peak flow in order to inflate the helmet as rapidly as possible. But why did we say that loss of synchronization can be an advantage? Because there are studies. This is a study by Richard, published in Intensive Care Medicine 2013, that shows that when you move from a fully synchronized mode, pressure assist control, to a non-synchronized mode, APRV, you can see there that the tidal volume goes up. And of course, increasing tidal volume means increased transpulmonary pressure swings. And almost the same results were demonstrated in this very nice study by Ritaya Mai, published in the Annals of Intensive Care. On the right-hand side, you can see that when you move from fully synchronized to non-synchronized modes, the average tidal volume decreases, the variability of tidal volume increases, and on the left-hand side, you can see that the transpulmonary pressure swings are lower with non-synchronized modes of assist. Another interesting observation comes from this study, and Laurent is the co-author of this. This was published in Critical Care, and this study shows that in patients that are receiving a non-invasive ventilation with the face mask or the helmet, with the same setup, so same pressures, you can see that on the right-hand side, you can see that the phase of helmet ventilation seems to be associated with an increase in and expiratory lung volume, so in sort of, which is a proxy of alveolar recruitment, better obtained with the helmet than with the face mask. So do we have clinical data that compare helmet and face mask for NIV? Well, this is probably the most famous study. This is a non-COVID study published in JAMA in 2016. This study was interrupted early after the inclusion of 83 adult patients. These were ARDS patients that had been managed with NIV for 8 hours, for 8 hours with face mask NIV, and then were randomized to helmet or face mask NIV. And as you can see here, the intubation rate was much lower with the helmet than with the face mask. There was no difference in the interface-related event, and there was also a significant difference in survival, which was a secondary aim of the study. And probably the point is, if you see there, with the face mask, the average PEEP level applied was 5 centimeters of water, while with the helmet, it was 8 centimeters of water. So a significant difference, significantly higher level of PEEP applied with the helmet rather than with the face mask. And this is a meta-analysis published in JAMA by Ferrero that shows that the use of the helmet as an interface for non-invasive ventilation compared to the face mask seems to be associated with a reduced rate of intubation and improved mortality, but all the data basically come on this comparison between helmet and face mask. They all come from the Patel study. There is only one study, which is the reason why in the new guidelines we basically were not able to issue any recommendation on this. This has been shown already. It's a study by Domenico Grieco. It's the Henevot study, 109 patients with acute hypoxemic respiratory failure due to COVID-19, and they were randomized to helmet and IV, applied continuously for at least 48 hours versus nasal high flow. You can see there the settings of the helmet. It was described already. and the primary outcome was the median number of days free of respiratory support at 28 days. We have heard this already, no difference in the primary outcome, but a significant difference in the intubation rate in favor of the helmet, and also a higher PF ratio with the helmet than with the face mask. And the last study has been shown already, is the Arabi study published in JAMA. This is a study on the helmet as the interface, because the comparator is usual respiratory support, which was a mixture of standard oxygen, nasal high flow, and face mask NIV, and the helmet was applied continuously for the first 48 hours. The primary outcome was mortality, and this study did not show difference in mortality or in the intubation rate. So we do not have definitive data on which interface is better. What I think is that CPAP is preferable, the helmet is preferable if you want to apply CPAP. For non-invasive ventilation, we still have many things to learn. Thank you very much for the attention.